So lumbar traction is next. Now, I have seen in my clinical practice lumbar traction work. Although when we look at the evidence, again, big research, the evidence regarding clinical efficacy of lumbar traction is conflicting. So that statement mirrors what my clinical practice. Some patients it works wonders for, other patients it does absolutely nothing for. And the research says that too. So just like a lot of things, what do we do with our whole practice? What is our entire career? Make a good clinical decision with the information you have at hand, try it, and then remeasure your patient to see if it's working. If it's not working, either you make adjustments within your treatments or you scrap that aspect and go a different route. So that's our whole career. So, lumbar traction is no different than that. The use of lumbar traction in low back pain remains inconclusive because of the lack of methodological rigor and limited application of clinical parameters used in clinical practice. So that statement's basically just saying that we don't have great guidelines because the research itself is all over the map. You can't just take anybody who has back pain and give them traction and say traction doesn't work. Well, no, it might work for a very specific type of patient, but not for everybody. There's a lot of, I like picking apart research. If we grabbed, 1,000 people with back pain and we said, okay, traction versus placebo traction, but my traction group was on average 5 years younger than my placebo group, who's going to get better faster? The younger group. If my traction group had a lower BMI by 2 points than my placebo group, who's going to get better faster? The lower BMI group, especially for things like back pain and osteoarthritis. I mean, those are mechanical problems that, just mass matters. So coming up with good research is tough, and application of it to our patients is difficult. So, but what are some of the physiological effects? Well, the vertebral separation is the number one thing that we are going to, that's the goal of it. Hopefully with that, we can also reduce disc protrusions with that. Increase that neuroforamen space, distraction of apophyseal joints, temporary reduction of scoliosis. Okay. Temporary increase in lordosis with extension traction. That could be something we really want to do. Decrease in lumbar paraspinal EMG activity. So that, what do I mean by temporary decrease in lumbar paraspinal EMG activity? What is that referring to? Yeah, and what is that how do we measure that EMG activity? With biofeedback, isn't that great? I was hoping Annie was gonna get it. I'm glad you got it though. Electromyographic. There's a bunch of ways to do it. In these studies, they probably implant something into the muscle itself to get a better measure of it. That's fun. So our clinical considerations are the same. What position do I want my patient in? How much poundage? What's my line of pull? Do I want static versus intermittent? How much treatment time? How frequent should the treatment be? What equipment do I need? Do I want manual traction? Man, you guys had, for cervical traction, how much is the average headway? So grabbing that head and trying to give it a distraction with how much force generally do we need? 20 to 25 pounds. So yeah, that's a lot of work. Does that sound like you guys want to do cervical traction all day long? Really tough. Anybody ever want to take a crack at lumbar traction? What do you think? You think that's a lot of work, a little work? Do you think it's harder or easier than cervical traction? By a lot, right? So manual traction is, I will personally tell you, and maybe this is just because I'm a lazy therapist, I would advise you to steer clear of that any chance you get. But and then we'll talk about positional traction too. So there's, as far as patient position goes, no difference in electrical activity of the back musculature between prone and supine positions. Current trends include positioning the patient in a supine position with hips and knees extended and in prone, depending on the target tissue desired. So with supine position with the hips flexed to around 70 degrees, that's where those legs were on those footstools, if you remember it in the cervical traction. That increases vertebral spaces at all levels of the lumbar spine. So that's great. You got general stenosis. That's going to open things up. That's going to be pretty good. Prone will also allow concurrent modalities. So if we wanted to add heat or ice as well, probably makes most sense for a thermal or a heat modality. You can increase spacing of all intervertebral discs as well. You're looking awfully skeptical there, Brianne.
That's just.
Yeah. Yeah, we're going to get more into the position in a little bit, especially when we start going back there. The line of pull is the next thing that we've got to really start thinking about. Because of the anatomy, I'll also talk about some general treatment strategies as well. So next up, poundage, necessary to overcome frictional forces of the lower body with a thoracic harness, and the absence of a split table is 1/4 body weight. All right, so here's what we want. Research has a wide range of acceptable intensities. Between 30 and 60% of body weight is what the research will tell us. That's the low to high ranges that we would need to be effective. Some other research says 44%, some other research says 50%. The most common ones that I see is 50% body weight. That is always my personal clinical goal. Some research says as low as 30% can be effective. So what do we do with cervical traction? What's the poundage range? 25 to 30 pounds. So how do we apply that to our patients? First time with the patient doing traction, what do? Start low, right? Make sure the patient can tolerate, make sure they're happy. Make sure we don't pop their head off. No. And maybe if we started at 25 with lots of steps to get up there, maybe she would tolerate that. And then maybe next time she would be able to come in and say, no, that wasn't so bad. So that's exactly how I use this 30 to 60%. My clinical goal is at 50% is the minimum that my clinical goal, because the most research tells us it's closer to that 50% body weight. But the first time I'm with my patient, especially if they're nervous, I can go as low as 30% and be okay. Also important, cadaver studies show the tolerance of the T11, T12 force to be 440 pounds. Again, great study. Let's grab a bunch of cadavers. Yeah, but boss, where are we going to get these cadavers? I know of a place. Drive by it every week. I saw a couple of new people in. So we've got plenty of poundage between clinically effective to safe. We've got a big middle ground of that. So that's really great for us. And it could be important for our patients. Maybe they don't have the same type of humor that I have, where I say, no, don't worry, in cadavers. But that is nice for us to know and for our patients to understand at some point too. So That was just a different research. The three biggest research articles has between 30 and 60% effectiveness, 44% and 50%. The most research that I see is closer to 50% body weight. Some research has as low as 30% be effective. I think that's a little light, but if my patient can tolerate 30% and I can also measure progress, I don't need to do anything. We're getting better with light poundage. Great. My personal clinical goal is 50% body weight, but I'm going to start as low as 30% for the day one. So we have split tables. Anybody have used traction in their clinical sites, their sites they work with? Yeah. You guys have a split table like we have? Yeah. Anybody, you've used traction, but you've used lumbar personally. Do you remember if that table slid or not? Okay. Gotcha. Good. Any others? Did you have? Okay. Do you have traction at your place?
Okay, I have a black one. that you
Yeah.
put on the table.
Oh, yeah, like this,
No, not that.
the cervical one?
Yeah.
Oh, okay. And lumbar traction, have you?
I asked my boss, he said this should be in the basement, because he says we didn't use it that much.
Yeah,
Because I was wondering, I was like, I didn't see it, so it should be in the basement.
all right.
I feel like. Oh, yeah, that's like, around, like, the PC, put it around, you get on the table.
Yeah. There's a few different ways to use that. It could be manual traction. So we're going to be using machines for our purposes here. We could do manual traction if we wanted to. There's a lot of things where you're using belts around patients and the therapist's body weight. It could be hip distraction and not necessarily lumbar. I'd have to see the exact technique, but yes, that's an option. So if we are going to be using traction frequently in our clinic, I suggest spending the money. It is expensive, but spending the money on a nice traction unit. One, I get to set it and forget it. I get to set the patient up. As long as they're happy, great. Timer will go off. Press the button if you need to. Please don't press the button because I have notes to do, right? The manual traction, one, I've got to be there applying the force. Two, I've got to apply this force, like 50% body weight, even for really light people. That's a ton of force. So the best thing I can offer is convince your clinic owners to spend money on a split table. If we can still do traction even with machine without a split table, although we have this friction force that we have to consider. Because if we want 50% of body weight force to the lumbar spine, but some of the table is taking up that force because of that friction involved. So we have to account for that. So the coefficient of static friction when a person's on a treatment table is about 0.5 using a solid table, not a split table like we have. So when we calculate how much force is going into the lumbar spine itself, we have to account for that. So roughly, you know, this 160-pound patient, 80 pounds weighs on the bottom half, 40 pounds weighs on the top half. If we apply 100 pounds of force, well, we have 80 pounds, but multiply it by 0.5. So there's 40 pounds of traction, 40 pounds of friction that we have to overcome. So if we have only 60 pounds of traction is actually being introduced to the lumbar spine. So that is part of the calculation that we would have to start going with. Now, luckily, you know, cadaver studies tell us that the lumbar spine can withstand up to 440 pounds of pressure. So we've got a lot of wiggle room to play with, but this is part of the calculations that if we don't have a split level that we would have to take into account. But luckily for us, we have split table. What's the matter, Brand? Nothing. Everything. Patho on the brain when nobody's paying attention today. All right, so the line of pull is going to, I've got a couple things that's going to help us figure out our treatment positions, and line of pull is one of them. So the angle of traction force on the pelvis can ultimately determine the low back position during traction and be more important than patient position. To maximize separation of the pull of traction should occur perpendicular to the force, the surfaces we're trying to act upon it. The upper lumbar discs, if that's what we're trying to work on, the rope should be relatively horizontal. Now, relatively horizontal because our patients are of a whole bunch of different sizes and our tables can only go in certain positions. So you have a little bit of wiggle room there. Relatively horizontal is a nice wiggle room for you. If we want the lowest L5S1 area, then we need a 30-degree angle of pull. And here's our anatomy there. So, Rob, can you come on this side here? All right, so this is where our patient is. Our patient's in what position here? Prone or supine? Prone or supine. Okay. So in the prone position, if we have a horizontal line of pull, just get on that side of the cart there and get your ends. Yeah, good. So, whoa, look at that. All right, so if we have a relatively horizontal line of pull in the prone position, you can see how more of the upper lumbar discs, we're going to get great separation there. What's happening at this disc, though? We get kind of like a little bit of distraction on the anterior side, but on the posterior side, we might get a little compression just because of the line of pull isn't great, right? Yours goes up a little bit higher, a little bit higher, a little bit higher, a little bit higher. There you go. Do you see how that line of pull now would distract this disc completely, or the space for it? Does that make a little bit of more sense? Okay. And that's just because of the curvature of our spine, right? So that's in the prone position. Let's go over to, ooh, look at me learning how to use this thing. All right, so if in the supine position, relatively horizontal line of pull, upper discs, makes sense, right? Go down, there you go. You see how that line of pull, the closer to 30-degree line of pull, now is going to target that L5S1 disc most appropriately. Do you see that? Great. Thank you. So, so the line of pull is going to matter greatly. And I think the line of pull we're trying for is going to matter a little bit more than what my patient's position is because of the effects on the anatomy. With our machines here, we don't have the luxury of the traction unit being lower than the machine, than the table, I should say. So in order to achieve that line of pull, the table has to be lower than the traction unit. And to get the 30-degree line of pull, my patient has to be in prone for that. Once we once we get back there, you'll be able to see that a little bit better. Not every unit is that way, but that is something for us to consider. So other things to consider for the line of pulls, some harnesses can promote more lordosis or kyphosis, depending on the relative placement of the two halves of it. Potentially supine with legs straight and a harness harness used to promote lordosis may be indicated for more of a disc protrusion. Supine with lower extremities flexed to 90 degrees with kyphosis might be indicated for lateral stenosis secondary to spondylosis. And unilateral traction can potentially be helpful for stenosis or lateral disc protrusion. To achieve that, we can either place the patient askew. That's a fun word. I don't say askew enough in my vocabulary. Do you guys use askew a lot? When's the last time you used that word? So maybe just biasing our patient would introduce more of a unilateral pull, or don't use a spreader bar. We'll look at that when we go back there and actually get this on us. All right, static versus intermittent. Same rules as cervical traction. Static, better for muscle relaxation, facet joint capsule stretching. Intermittent, better for pain relief, more comfortable for most patients. Shorter the time of pull, the more poundage can generally be tolerated. If we want facet distraction, 10 and 10. If we have a herniated disc, a 1-to-3 ratio, 20 seconds on, 60 seconds off is generally applied. Treatment time depends on the desired effects. Shorter for disc herniations, longer for spondylosis. Traction for longer than 8 minutes with disc protrusions can cause the disc to imbibe excess fluid and decrease intradiscal pressure. So we want to stay shorter than that. And that's the same amount of time for our cervical traction as well, right? 8 minutes for disc, 20 to 25 minutes for everything else, right? So that's good. The frequency of traction depends on the patient. How severe is the problem? Are we seeing benefit from it? If they're not seeing benefit, come in more often. We're not seeing benefit. It does make sense. So generally, the more severe the problem, the greater the frequency of treatment. That makes sense for anything we do, right? Now, we could use gravity-assisted traction. Inversion tables are the most common version of that I've seen. I think we talked a little bit about those bars that go in doorways with the boots that hang on. That was another way you could do that. So depending on what the machine, that the device that you're using, it will depend on how much force is applied. But both inversion techniques create a lumbar traction force about 40% body weight. So we're getting pretty close to how much we want. Although for inversion traction, we do have a contraindication if we have cardiac or respiratory insufficiency. That has to do with why? Why is that? The gravity is pulling the blood to the heart and lungs. If we have insufficiency already, then we're not gonna tolerate that. You guys know anything about the cardiac system? Blood? No, I don't feel like I know anything. Yeah. As I just drank that water, talk to me about the GI and urinary system. Where's it go? Where's the path? That's great. It stops there. Briefly, manual traction, longitudinal traction force locking techniques using unison with 3-dimensional pulls. Positional traction using the weight of legs as traction force. I haven't seen a lot of benefit. With my patients trying to do this. So I don't really want to spend a lot of time on that. So our procedure, obviously always chart review, prepare everything you need. preset all of your parameters, obtain consent, and educate the patient. When we apply I think the motor aspect for us as clinicians, and what's going to be the thing that we need a lot of reps on, is the application of all of the straps and the harnesses. That's the thing that's going to be tough. So the pelvic harness should be in line with the umbilicus. The thoracic harness should be snugly around the ribs, 8, 9, and 10. The harnesses will overlap. Attach the spreader bar, remove all slack, double check all your settings, educate the patient on the shutoff bell and the emergency switch, the shutoff switch. I had talked to everybody before. When we have cervical traction, it's really nice if we can find a way to loop the shutoff button somewhere on the patient. So if they do fall asleep or they just lose grip on it, it doesn't fall on the floor. With our lumbar traction, we've got plenty of loops and straps to loop this in with our patient, and that's going to be really important. Before we press start, we want to make sure we release the split table and then turn on and wait at least one cycle with your patient. I tell myself, no, the cycle's not done. Can't leave yet. Stay here. That's tough for me to wait. Now, the first time I apply this to my patient, I'm probably waiting with them. At least half the treatment I'm waiting with them. If it's the first time. I bring my notes back there. After that, wait at least one cycle, everything good. Okay, let's get out of here. You enjoy. Yep. I asked their body weight. Yeah. And if they don't have any idea, then I always have scales, and I have a scale in my car right now, actually, for my treatments. 2 reasons is, one, this is important for us we have a little bit of wiggle room, 30 to 60% body weight. So we've got a lot of wiggle room for that. So if we shoot for half, even if they're 20 pounds off, we're probably going to be within that acceptable range. But I always have a scale with me. I always have a scale at the home care. There's 2 reasons for it. One, when an orthopedic surgeon gives me weight bearing restrictions by the pound. So the 2 weight bearing restrictions, if it's partial weight bearing, sometimes they say can weight bear, 25 pounds initially, then an extra 20 pounds per week until full weight bearing. All right, well, in order for get my patient to feel what that is, I have a scale that they get to look at. So that's one thing. Sometimes docs will prescribe percentage of body weights, can weight bear 25%, and then an extra 5% each week until full weight bearing. So then we have to have that conversation. What do you weigh? And then the other reason in the home care setting, it's really important, congestive heart failure. Right? Because the more they're holding on to water, the more their cardiac system has to work harder. And if they gain more than 2 pounds in a day or 5 pounds in a week, then it's a call to the cardiologist, and they're going to up the diuretic to get rid of that water. So, but anyway, yeah. So asking the patient, they tell us an answer, great. And I don't. Maybe this is a conversation that I think we had in an exercise class where you said, yeah, but how do you do that in a nice way? I said, I don't know. I'm asking your weight because we need to know for this treatment. It's not because I'm running and gossiping. It's not because I care. I care because I need to know it for this reason, right? So just like if doc's going to prescribe medication and they need to know how much you weigh because the amount of medication depends on your body weight, we just need to know that. That's not a personality thing. That's not, it's got to know. So, hey, I've got to set this to our first treatment is going to be 30% body weight. We're going to climb up to 50% if you can tolerate it. How much do you weigh? And we can calculate that. Yeah. I wouldn't say, hey, great to see you. How's the knee? What do you weigh? Like, it's not, that's probably not. If you want to know how to do it nicely, Sarah can tell us how. One of my favorite conversations I've had this year is, yeah, but how do you do that in a nice way? Yeah. So documentation, type of traction, pace and position. If we have different harness types, you can use that. What track mode? If you have any ramping, either progressive or regressive, I think is what the machines call it. We can describe that as well. The exact poundage. Treatment time, including the on-off times in our soap notes that we saw. I think that was one of the more common problems with our NMES type modalities. Giving me the ratio isn't good enough. I know what the ratio should be. NMES, it's either 1 to 3 or 1 to 5 on the strengthening protocol. You don't need to give me that. I need to know exactly how many seconds you did on and off, because that's what you applied to your patient. And then potentially patient response. All right, any questions right now on lumbar traction? All right, so we've got a few ways to think about this when we apply it to our patient. The line of pull is going to dictate much more for our patient position than should my patient be in supine leg straight versus knees flexed. If I need that 30-degree line of pull on the machines we have here, the patient has to be in prone. If we are at the upper lumbar region, then a relatively horizontal, and we can decide if we want our patient supine or prone. First gut feeling, why would you choose supine or prone if we can get relatively horizontal for both? Patient comfort. Yeah, that's probably the number one thing that we have to consider. Most comfortable is probably what? Supine with legs flexed to 70 degrees. That's probably the most comfortable. And you know what? It opens everything up the best anyway. So man, you get what you want. I get what I want. Great. This is a win-win. There is some treatment approaches for disc protrusions that we would want to force extension, because which directions does the disc protrude? Posteriorly. So if we do distraction with extension work, then that theoretically is going to drive that disc back to the central where it should be, and it's going to centralize that disc and relieve symptoms. So how would we apply that thinking to our traction? What patient position would we want if that's what we want? Prone probably makes the most sense now. So there's, just like with everything, there's a good thought process, and you make a good clinical decision. No, this is exactly what I want. And then you apply it and you remeasure with the patient. If my patient can't tolerate prone, okay, I'll try supine then. Because all we can do is, being a clinical-based problem solver, make your best clinical judgment, and then you fix along the way. So line of pull is the first thing. That's the concrete, right? So if we need that 30-degree line of pull, if we're on L5S1, we need a 30-degree line of pull. On these machines, you have to be in prone for it. The others, relatively horizontal, I can choose supine or prone. Supine is probably supine with the knees flexed to 70 degrees is the most beneficial for me clinically, because I get to open up everything really efficiently. It's probably the most comfortable for the patient as well. Great. If you have that treatment that you want, you're saying, okay, I've tried that, we're not getting the results we want. We're going to try prone because that's going to increase the extension work as we do this. Great. That's something else you can try. All right. Do we have any questions on position now? Yeah. Yeah, it's a great question. I don't know the answer to that. Yeah. Now, something that I would make your best decision based on the information you're given. You try something and then you remeasure to see if it's good or not, right? So I would try to match what I think the bigger problem is, and I would attack the bigger problem. Yeah. That's what I would match their physical symptoms more. Actually, I hate when patients tell me they've had an MRI, just like what Dan was saying, right? You know, I don't care about your diagnostic imaging. I care what you're complaining about and what I can figure out. So yeah, I try to match that clinically. And I think that's a really important conversation to have with the PT that does the evaluation, because that's a big part of that. That's a great question. All right, any other questions? All right, so